thinking of HIV and the other gender-related issues, because the project is supporting. And also we need to understand the link, how public meetings and TB case notification through those meetings, because we have seen the yielding, and we cannot do this if at all we don't have any strong and collaborative effort with the community members, including the ward executive officers, the village people, and the other people, and the communities themselves, because they need serious and serious engagement for the case notification. So this work would have not been achieved if at all I will not recognize the support from the USAID through the our client partner, the Health Africa in Tanzania, but the Ministry of Health under the National TB and Leprosy Program, but also the dedicated team, the game changers, the community health workers. They are very crucial, very important when they collaborate with the world executive officers, because those are the ones who brought up these results within the shortest period. We can see a good changes with that. So for more references regarding this good work, which is being on the public meetings, we should not take them as granted. Let's look for the USAID Afashirikishi program, which is currently being implemented in 9 regions of Tanzania, including Mwanza and Geita region, as we have seen the yields here. Thank you so much.
Thank you very much, Ms. Rabia, for this collaborative presentation.
Okay, good afternoon. My name is Ashraf Mkumba. I am a health and HIV officer. I work with SHDEPHA in implementation of USAID Kizazi Hodari project in Morogoro region. Through the programs where I'm very experienced in providing the services to the community to fulfill the community needs in improving their health and well-being. I would like to welcome you through this afternoon through the journey of our basic of our lesson learned as a lesson learned abstract from experience based on USAID Kizazi Hodari programs. Our title will be the Scaling Up Nutritional Support and Care to Promote a Good Prognosis for Malnourished HIV Positive Children enrolling in VC programs. As we all know that improving nutritional statuses is crucial for reducing the mortality among children living with HIV, as it improves the CD4 count and help it to attain viral suppression. Improving nutritional status among children, as we all know that it accumulates the most and very essential nutrients, both macro and micronutrients, that help the body to generate the immunity that will help them to fight against infection. So as we all know that these children living with HIV, they need improved nutritional status to make sure that they have a plentiful macronutrient and micronutrient to improve the CD4 count and help them to fight against infection. Hence, they will get the viral suppressions. Malnutrition interfere with the effectiveness of antiretroviral therapy, ARTs, and can proceed to premature death among most involved countries. We all know that the malnutrition and HIVs create some sort of vicious cycle that everyone it affects another in other way to make sure that, to deteriorate the health of these children. So malnutrition will interfere with ART in, as I said before, that the good nutrition, it will improve the proliferations of the cell that will help them to fight against infection. So once these children having the malnutrition, the ability of body to withstand with the effect of the ARVs will be compromised. Therefore, the burden of undernutrition globally, it accounts for 45%. Most among the children with HIV. Therefore, the integrated HIV services and with the nutritional programs is essential for optimal health and for optimal treatment outcome. These children living with HIV, they are faced, most of them, they are faced with undernutrition, because as we all know that these children have increased the demand of the food due to the demand of a nutrient due to the use of ARVs. Therefore, There are also these children, most of them, if they are not taking ART properly, they may face up with malabsorptions and the diarrhea are the sign and the symptoms of what? Opportunistic infection. So therefore, that's why it's count for almost 45% for those children living with HIV, they end up getting with what? Malnutrition. Thank you. Under SHDEPHA, we implement the USAID Kirazodari programs, the funded programs. So aim of this abstract is to address the gap on the implemented activities to, for those CLHIV's beneficiaries enrolled in overseas programs after being discharged from hospital to home for supportive and rehabilitative treatment. So under Kirazodari, we also we work with 240 community volunteers who are trained to provide the case management services at household. And out of them, most of them, they were trained to perform nutrition assessment in household level to those beneficiaries under 5. So with this activity, they use the job weight called the mean upper arm circumference system, and those findings they were reported through USSD data entry. Through the sample analysis were connected with the NXLs, and from the reported beneficiaries enrollment systems were analyzed. The results were from October 2022 to June 2023. CSW, that community volunteers, they are managed to conduct nutrition assessment to almost 1,569 overseas or children enrolled in programs. Among them, 95% were reported not malnourished, where 8 were reported moderate malnourished, 4 were reported and confirmed severely malnourished. The programs intervened to those beneficiaries who were malnourished through providing them with educational counseling, nutritional and educational counseling, and escorted those beneficiaries to high-level facilities, getting them supported with a further treatment. So there was a satisfactory prognosis to those beneficiaries who were reported and confirmed being malnourished, alongside their rehabilitative and supportive treatment. The programs also offer educational rather than providing them with food item support. So as we all know that when we implementing implementing a nutritional program, we should integrate with a nutritional intervention. Can either be nutritional sensitive to cover those behaviors that will help them to improve their health, and also can either be nutrition specific to cover the immediate cause of nutrition.
Time is up. You can just finalize.
Okay, thank you. Lesson learned. A collaborative efforts to involve multiple stakeholders within the community is essential for effective implementation of nutrition assessment. Also, engaging and supporting community health workers is also essential for educating them and also essential for education and financial facilitations. An adequate budget allocation is needed to cover for the severe malnourished beneficiaries, as we all know that overseas programs, it's provide the room for them more to rely on education rather than providing the supplements or providing them with the ready to use the therapeutic foods and those supplements that needed to rescue them from the malnourished. I would like to thank my teams, SHDEPHA Plus, and also ELCT as our prime partners, also Morogoro Council and community volunteers who supported me in providing this best lesson learned abstract to you this day. Thank you so much.
Thank you, Ashraf, for your nice presentation.
Barini Zamchana. My name is Rafael Seke. I work with SHDEPHA Plus in Arusha, implementing a USAID funded project called EPIC. So I will take you through the abstract titled Integration of HIV test self-test during index testing services resulted in reaching more listed partner and high case detection in Arusha. So during the implementation of EPIC project, index testing has been among the best performing testing modalities on reaching and identifying the new cases. However, the modality has been facing some challenges during its implementation. The main two challenges that led to this innovation were: number one, there was an increased number of listed contacts that were not reached These were the hard to reach, not because of their geographical location, but because of their attitude toward HIV and AIDS. Number two, the clients that were identified positive were willing to invite their partner for index testing service, but they feared to disclose their solo status to their partners due to fear of stigma, discrimination, but also violence. So the project thought of integrating HIV self-test with index testing, since HIV self-test is among the best modalities to reach the hard-to-reach individuals. So in integrating HIV self-test, to ensure that these two modalities and this innovation is possible, the project oriented and trained a number of peer educators who are responsible to orient these beneficiaries during the SPCC, during the SM. So the peer educators were trained. These are the ones responsible to orient, to provide an initial orientation to beneficiaries during the SPCC sessions. The project also trained a number of healthcare providers on index testing and HIV self-test, but also oriented these providers on how to successfully integrate the two modalities and ensure that unreached listed index contact are reached easily. So during the elicitation counseling, the healthcare provider is responsible to orient technically this client on how to correctly use the HIV self-test, but also how the healthcare provider will assist this person to disclose the solo status to the partner, but also will assist will solve all the questions that this client has regarding HIV self-test. So all eligible clients were given HIV self-test kits for their partner, and in a duration of 14 days, depending with the agreed time and place where the conventional test will be done, the healthcare provider provided the self-test kits to this beneficiary. The eligibility was measured in two things. First, the cooperation between the healthcare provider and the beneficiary. If the beneficiary is cooperative and assured that he or she will return the self-test kits, this person was counted eligible. But also, the person who was screened, we were conducting a screening for intimate partner violence. So those who were screened and found that they're not in a risk of being violated with their partner when taking the HIV self-test kits, they were considered as eligible clients and provided with the self-test kits. So the documentation of this data was documented on both governmental and projects customized tools. So the integrated HTS register was used to document, but also the customized index counter book, that is the project one customized, the customized provider's daily summary, but also the analysis was done through the customized database of the project, the government THS tool, but also a special customized Excel tool that was used to analyze the outcome of these services, this integration of HIV self-test and index. So we can see the outcome and the duration of 6 months. This was the outcome from October 2022 to March 2023. So we can see 67% of all kits that were collected. 67% of all clients that were listed, the kits were collected for them to conduct, to have an assisted modality of HIV self-test. Out of all clients, we managed to reach 89% of all kits that were collected, and out of that, 99% of all clients reached were tested, and we obtained a case detection of 27%. Under the normal testing modality of index testing, we can see that we managed to reach 90% of all clients that were reached, 88%, but managed to test 90% of them, and our case detection was 20%. So with this outcome and this that we have seen earlier, this shows that HIV self-test, integrating it with index testing has become significant and ensure that the unreached listed contact are reached very easy. So EPIC has planned to scale up and reach other regions of implementation with this modality to ensure that we reach all the unreached index contacts. But also with further studies and investigation, policymakers and other implementers may consider using this modality to ensure that all unreached clients are reached with the services. So I would like to acknowledge the support of the government, from the ministry and the regional and council's health management team, but also would like to appreciate the generous support of the United States government through PEPFAR, USA, but also SHDEPHA Plus and SHDEPHA who are the direct implementers of the project in Arusha. Asanteni sana.
Good afternoon. My name is Guarugano Katolika. I'm working with SHDEPHA Plus. I'm going to take you through the abstract on evaluating the community scorecard in addressing COVID-19 hesitance among the community members in the Mwanza and the Shinyanga region, as the experience from CPRC Global Vax project, which implemented in two regions of Shinyanga and the Mwanza region. Community scorecard is a social accountability tools which provide the opportunity to the community to be engaged on identification of the problem or identification of the concerning, and then together we develop the local driven solution to deal on that challenges. As we know that COVID-19 vaccination was the one of the intervention against the outbreak of the COVID-19 infection. But on implementation of the COVID-19 vaccination, one of the challenges was the acceptance of the vaccination among the community. So through that project, SHDEPHA Plus, together with the Americares in support from USAID, we conducted this project to provide the vaccination, but also to come with a solution on how to deal with the COVID-19 vaccination hesitance. So the main objective was to identify the challenges related to COVID-19 vaccination and to develop the driven and local solution at the village level or at the community level to provide the sense of ownership of that challenges, but also the ownership of the solution developed so that to come up with the good that. So during the project, we conducted a community scorecard across 246 villages across four districts in the Mwanza region and 2 districts in Shinyanga region. During the community scorecard, we used the focus group, 5 focus group discussions, which involve group of men, group of women, group of youth, community leaders, and healthcare providers. We selected those groups because they are the key groups at the community. And the main reason was to get the experience, thoughts, and the challenges from the across all groups at the community, so that when we come up with a solution, which come from each group, which create the sense of community. So also we use each focus group contains 12 participants at each focus group, and we use the developing the interview tool so that to cut the thoughts and the concern regarding the COVID-19 vaccination. After that, we use those experience, thoughts, and challenges which discussed in focus group to create or to develop the action plan, which was used to to work on those challenges developed or discussed from the focus groups. And then after developing the action plan, then we provide the time to work or to implement those actions developed from the focus groups. Yeah. After that, after the analysis, we revealed that the main reason for hastings were awareness gap, fear, myth, and misinformation. So during community scorecard implementation, we managed to work on those identified gaps, and we come up with the results. 62% of the participants who were not vaccinated were vaccinated during the community scorecard meetings, but also after quarterly assessment, we identified that there was increase in 20% of vaccination uptake. Yeah. In conclusion, the community scorecard approach is the one of the approach which provides community engagement and strengthens the community driven. So we think that the approach can be used to strengthen health system, to promote primary health care, and to ensure health care is accessible, and for especially when, as we discussed, it is providing the ownership of the community, so it can be adapted for implementation of other public health. We acknowledge the RHMTs of Mwanza in the Shinyanga regions, but also USAID and Anglicans and the SHDEPHA Plus management for their support on this one. Thank you.
From SHDEPHA Plus, as project coordinator for CPRC Global Vax Project, and I welcome you to our presentation. Our presentation will focus on the power of community engagement, a case report focusing on transforming attitudes towards COVID-19 vaccine through community scorecard meetings. As my colleague earlier presented, community scorecard is a community-led monitoring tool that focuses on addressing various concerns that are brought by the community, and it brings together the demand side of the health services, being the community, and the provider side of the supply side of the health services, being community volunteers, community workers, and providers at facility level. So SHDEPHA Plus, through CPRC Global Vax Project, what we did, we conducted various community scorecard meetings in villages across Mwanza and Shinyanga regions, and through these community scorecard meetings, we were able to address the various concerns and challenges that community members had regarding COVID-19 vaccines. And these challenges mainly were being brought up to address why they're not being vaccinated or why they're not receiving COVID-19 vaccine. So as the main focus of our abstract is one of the key success stories that we got through community scorecard, where we're going to meet, she's called Veronica Misana Mamajila. Veronica Misana Misango. She's an evangelist in Mamajila district, Mamajila ward in Kwimba district, Mwanza region, Tanzania. So Veronica, before she came to the community scorecard meeting, she had not been vaccinated, but when she came, she also had various reasons why she had not been vaccinated. One of them being that if you become vaccinated as a woman, you will not give birth, or you will give birth to deformed babies, various rumors that were being heard in the community. So we invited her to the community scorecard meeting, her being an influential leader, because she's a religious leader, and also we were able to hear what concerns she had. So during the meeting, she could hear people bring up these concerns, and health providers that were in the meetings, they were able to educate and address these concerns about COVID-19 vaccine. So Veronica took it upon herself that as a community leader, she should go ahead and be vaccinated. And at the end of the community scorecard meeting, she raised her hand and said, I want to be vaccinated. And good thing that the community scorecard meeting was being conducted at the health facility. So she chose to be vaccinated, you can see in the picture here. And thanks to her being vaccinated, we were able to vaccinate a total of 20 people through the meeting. And afterwards, when we went for a community scorecard review meeting, which we did after 3 months in the initial meeting. So after 3 months, we went to call the same people, and they were able to testify that through Veronica being vaccinated, they were also able to go and encourage other people in the community to be vaccinated. So Veronica became like an agent of change through the community scorecard, and it also showed that her efforts to be vaccinated caused a ripple effect in the whole community, where she was able to influence other people to be vaccinated. Yes. So this success story is an example of how the transformative power of engaging communities and engaging the users, the main users of the health services, whereby they're able to give their side or give their views on how they perceive the services being delivered at both community and facility settings. Also, by addressing vaccine hesitancy through community scorecard, local leaders and stakeholders, they empowered individuals like Veronica, they're able to make informed decisions that also influenced the whole community at large and led to health promotion in the community. Last but not least, I'd like to thank the Council Health Management Team of Kwimba DC, the Regional Health Management Team of Mwanza, and also thank my colleagues and I from SHDEPHA Plus and Americas through USAID, and USAID through Americas, sorry, for support for the project and their technical support and financial support on the project. Last but not least, I'm also thanking the community members, the health workers, and other stakeholders that are involved throughout the project. Thank you.
Okay, good morning. My name is Gladys Galvez, and I'm a Community Engagement Officer from USAID project at Msalala District in Shinyanga region, and I'm working with SHDEPHA Plus Kahama. And by starting, I'd like to introduce my abstract on qualitative studies about the uncovering of implementation of free exposure prophylaxis program to adolescent girls and young women in Tanzania Health. And as we all know, among priority population which is at high risk to acquire HIV infection is adolescent girls known as HYW, and these are girls, young girls, age of 15 to 24 years. As we all know, the incidence in Tanzania to HYW is very high, and despite all the efforts done by NGOs, governments, and other stakeholders on reducing the incidence of HIV infection, especially to HYW, is quite high. But still, as we all know, WHO recommended PrEP as a major negative cascade, which will help to prevent HIV from acquiring new infection. But in spite of the efforts, the PrEP awareness for adolescent girls and young women uptake has been lower than expected, even if those ages are at high risk due to gender social power disparities, which contribute to HIV infections, include the engagement in transsexual sex, condom-less sex, the age disparities, sexual partners. A qualitative sample survey was conducted, which was assessing current knowledge, perception, and attitude on pre-exposure prophylaxis uptake to adolescent girls in Msalala DC, Shinyanga region. And the research was conducted within 1 year, from June 2022 to June 2023, whereby convenient sampling was conducted to 26 individuals, including 4 healthcare providers and 22 HYW who was in active service at that time. And 5 focus groups in composition were almost like 5 to 4 HYW putting together, and we let them open discuss about how did they feel, how were their perception before and after. And each focus group, the data was collected through questionnaires, and at the first we assessed the healthcare providers' medical practice on PrEP initiation and PrEP refill, and then on the second we were also assessed the PrEP knowledge and use perception and attitude among HYW. On the results part, the first thing that we found was more than half of providers that we were having the same discussion about PrEP initiation. Thank you. Also, half of healthcare providers that are providing PrEP services to AGI were saying like it's really important for AGI to start using PrEP. As we all know and we all are aware about our traditional beliefs and all the social and gender issues that highly affect HYW. And on part of, we also look not only on the part of the side effect, and because we all know that a lot of healthcare providers, they're providing information about the side effect of the drug and all the HY that we try to discuss the issues where so possible, and it seems that they are all aware about PrEP and the side effect, and everything was not a big deal for them. But we found, I would say we found some statement that will show it will shock us at that time that the resemblance of PrEP to antiretroviral drug, which was about 95% of HY reported as a major barrier to PrEP uptake. One HY said, once my friend says I'm HIV positive, that's why I use PrEP. And a lot of HY, it seems like they get confused because some of drugs, PrEP drug, it resembles the ARV. Then another thing that we found was, as we all know, before taking PrEP, we're supposed to take a creatinine test for HYW. So the creatinine test that conducted before uptake of PrEP was associated with witchcraft and Freemasons belief. As HY say, my blood will be used for Freemasons ritual and or maybe could be sold. And number 3 was the lack of information among communities, parenting stigma associated with the assumption of promiscuity, which take like 75%. They say parents believe the use of PrEP accelerates risky behavior or prostitution behavior to HYW. Now we came to because of time, we have a simple audio that we could I could pray so that we could hear some of our discussion with HYWs about PrEP uptake. So because of the time, I would like to do it in the end if moderator will allow me. Now it comes to the finding that we all identify that our research done led us to significant insight regarding PrEP uptake, resistance to adolescents, girls and young women. We identified that critical reasons behind PrEP uptake, hesitance, including awareness gap, fear, misinformation, and stigma. On part of conclusion, PrEP perceived as a variable HIV prevention tools to ensure the accessibility of PrEP among HYW in Tanzania. Efforts should focus on reducing stigma, fostering social support for PrEP use, and framing the PrEP campaign positively to raise community awareness. And I would like to acknowledge my work to Council for Health and Management Team and Services Provider from Salala DC, Shinyanga region. Also SHDEPHA Plus Management for their immense support, technical assistance and encouragement. And last but not least, I would like to recognize the contribution of healthcare workers, peer educators and adolescents, girls and young women at Salala region. Thank you. So in time to come, I would like to have a simple audio about our discussion. Like not more than 2 minutes.
Maybe for 1 minute.
Changamoto zipo, lakini ni yale tu maneno ya kizushi, yani unakutana na binti au benchiwani, unampa zile elimu vizuri kabisa, alafu anakuelewa. Sasa katika kutoa elimu, sinatoa elimu siku tofauti, na utatoa elimu hata huduma atapewa kesho, unakuta wale watu wanakusanyana kwa maneno ya kizushi, wanaanza kuambia zile sio dawa kinga, yani ni maneno ya kizushi tu, ni kwamba zile dawa mnadanganywa tu, ni madawa ambayo yanaleta madhara hata kwenye miili yenu hivyo. Kwa unakutana changamoto, unarudi kesho yake kumpa huyo ejiwai ile huduma, unakuta ameshabadilisha mtaalamu. Anasema zile dawa niliambiwa hapana. Zile dawa yani zina madhara. Zile dawa hamna. Kwanza ni za watu wanaoishi na maambukizi. Hata mlilete na lile kopo nilione kabla hamjanifanyia zile huduma. Unaona? Lakini pia wanakuwa na changamoto kwenye kuchukuliwa zile sample. Anasema kwamba mnadanganywa zile damu labda zinapelekwa kwa labda huko Freemason. Unaona? Mtasema zinapelekwa kwa Freemason. Mnadanganywa. Mtu mwingine anasema damu zenu zinaenda kuuzwa. Unaona? Lakini tunazidi kuwapa elimu kwa kuambia kwamba zile damu ni sample tu kwa ajili ya afya yako. Kwanza ni huduma
Hello, I think I'll end that. Thanks so much.
Thank you, Gladness, for your nice presentation.
Yeah, so good evening everyone, and thank you so much for joining this session. I'm presenting on behalf of my colleague, Venus Muzuka, who is the Executive Director of SHDEPHA Plus. So SHDEPHA was interested in this forum of who is who when it comes to provision of healthcare services in Tanzania. So can you go to the next slide, please? Yeah, so SHDEPHA is just an abbreviation which stands for Service Health and Development for People Living Positively with HIV/AIDS, and it was founded since 1994, November. And currently it operates in 11 regions of Tanzania, as we can see on the shaded blue map. So we are here legally as national NGO operating specifically in Tanzania mainland. We have key personnel or staffs who are supporting the implementation of different programs which are being supported by different donors, development donors and the other implementing partners who are implementing within Tanzania. As we can see, we focus on provision of health and social services. When it comes to health, now that is the three diseases like HIV, tuberculosis, malaria, and for economic empowerment, gender, GBV issues, which is being provided to the communities whom we serve, and education. So we have different programs whenever we mobilize resources, whenever we implement. This is the target where we are focusing on. But we don't just do it alone, as I earlier said. We do it by receiving funds from the donors like PEPFAR, USAID, CDC, but also other implementing partners who are implementing within the country. Like currently now we have a program supported by Tanzania, We have programs supported by ICAP, FHI 360, but not only those, we also have others who are supported by other civil society organizations like Foundation for Civil Society. Objectives, strategic plans. So far during 2019 to 2016, we have achieved a number of key results, especially when it comes to HIV prevention services, because we do prevention services like creating demand for the services to the targeted audience, doing the screening, but also engaging the healthcare providers when it comes to HIV testing services. When it comes to TB prevention, also SHDEPHA is doing a lot by engaging the community health workers who provide also health education for TB, symptom screening, identifying also presumptive TB cases, return collection, and at the end ensuring that people who have been confirmed with tuberculosis are being linked to treatment, but also adhere to their treatment. And when it comes to sexual and reproductive health, we do sensitization in terms of screening by ensuring that the adolescent girls and young women are following proper measures to protect themselves from like child spacing, as we can see. That's also combined with the maternal and newborn, so those are the areas of achievement. Orienting them on how they can strengthen the economic well-being by training them to join the village saving and landing groups, but also taking them, building their capacities to do better, scholarships and other apprenticeship programs. And in that way, they have improved their lifestyle, but risk of education, immunity infection, in a way that they can do their self-reliance. When it comes to gender-based violence, we work closely with the police gender desk, but also the health facilities where after we screen and identify people who have experience with TB, then they are being linked to services of their choice at respective institution, but also the remain in support with the organization. We also have programs related to education, as I said. So through the programs which currently we have, but also for the passive programs which we implemented, we support children in ensuring that they do they increase high passing rate in mathematics, science and mathematics, but also in providing some educational services, especially to these families where children who are HIV positive, and this has mostly been done through the orphans and vulnerable projects like Achieve and the Kizazi Hodari. So now, what is the impact which SHDEPHA is making in the country? And we can see some transformational change and empowerment that SHDEPHA, through its work, through its credible work done in the country. So we can see these are some of the clients acknowledging the services to which SHDEPHA is offering in the country. So looking here, this is Kabula Homa. So for her, she's 67 years old, and now she was reflecting herself on how she suffered of tuberculosis. And now I got her. I'm extremely grateful for the TB mobile van, because we also use the TB clinics to reach individuals in TB case findings. So without it, I would have remained unaware of my TB diagnosis, suffering in silence. The project has not only saved my life, but also empowered me to provide and care for my family, allowing me to lead the health life once again. So these are some of the acknowledgements, the testimonies from the community. It's because of the work which SHDEPHA is doing. So Helena also says, I have fully recovered from TB and now actively engaged in farming, and by then, before she was reached by the services which SHDEPHA is offering, she could not do anything, and she appreciates the great work which is done by the organization, and collaboration with the community health workers. Yeah, so other things we can see from Veronica, and because we work with influential leaders, like the church people, when it comes to like as emerging diseases like the COVID-19, so due to the stigma issues, the hesitance in accessing the vaccine uptake, we can also see changes on how they are advocates, they are game changer in influencing other community members to access the services. Next, please. Yeah, so we are looking forward to expand the services which we provide here in Tanzania, scaling up the successful innovations which we are making in the country, but also building the networking and partnership with you and in fostering the issue of collaboration. So as you can see, this is all about SHDEPHA, and it's because we want to form a strong networking, to form a strong partnership with you, and we are open, and I trust that through this beginning we can create and create a healthier world in Tanzania towards the universal health coverage so that we can end TB, malaria, and HIV. Thank you so much, and we always have a saying at our organization. When I say SHDEPHA Plus, so SHDEPHA team, you stand SHDEPHA Plus, together we are hope and life.